Good job on block 1 exam, y'all. It's good to see you again. Y'all did really well. Not too scary. Block 2 exam is very similar style, but it's a little thicker. So don't ease up off the gas pedal if you think, I got this. It's a little thicker, so we got to still pay attention. We'll keep practicing along the way so there won't be any surprises with it. Keep having that med lecture that we have from block 1. Keep that in the background because we've already covered all the meds. We'll have that in the background to reference back to other ones that we'll use again in different scenarios, different diagnoses. And then maybe 1 or 2, we'll have one-off meds that we haven't mentioned yet, but they'll be very specific for certain treatments. And I'll bring that to your attention as we go. Another important but heavy topic today. So, and I know this might have affected, is affecting, has affected you or someone you love. So again, if you need to take a break, and we'll just assume you're taking a bathroom break and no harm, no foul. Our goal is, as it is always, to protect those who can't protect themselves. And in this lecture, we're going to highlight those people, protecting those that can't protect themselves. My intent is to handle this respectfully and professionally and objectively, and in doing that, to hopefully lighten the subject a little bit. I'll add some of my own stories, but in no way do I mean for this to be insensitive or to rub you the wrong way or to trigger anybody in that way. So if you have suggestions on what I say that could be done better, please see me in my office afterwards. Happy to have those conversations. And ahead of time, I mean no harm when I'm talking about these things. So welcome your feedback. And again, those end-of-course surveys, IFAP, and we as individual instructors, we take those very seriously. So write your comments in there that can be anonymous. You can sign your name or not, either way. But we take those very seriously to make this better, IFAP better in this course in particular. So please. Now, this is my last time to teach this course, so you guys get to be the caboose of my psych career at IFAP. I think I've said that before, but excited to bring this to you. Here's what we're talking about today. Underline those 3, just more so to talk about, that's what we're talking about, focused in on the cause, set of cause, or manner of causation of these. That's etiology, types or different variations of abuse, and then indicators, things we want to watch for in clinic to be able to pick up on this and identify it early. And there's where it's found in our text. There are no official diagnoses in DSM for abuse, which is a point of contention in the psych world between a lot of people. So there are diagnoses in ICD-10, but in the DSM, the psych manual, there are no diagnoses. So we'll talk about that in that way. It's super very important topic what we'll cover here. All right, first up, child and elder abuse, what we're talking about today primarily, and neglect. Why do we single out these 2 groups, child and elder? More vulnerable, yep, they can't take care of themselves. Less ability to protect themselves. When we talk about injuries, when we're doing this, there will be some signs that are, none of these are pathognomonic. We'll have a chart I'll show you in a little bit that you'll need to know, and a lot of those repeat across ages, but we'll need to know those to raise our spidey sense and to say, I need to ask some more questions because I see this injury. Not all of it is, if I see this, then that means abuse. Don't jump to conclusions, but don't leave it off your differential. We need to have our spidey sense and train our emotional intelligence, reading the room when we walk in that exam room, and even before, to pick up on this. Super important. Certain injuries should raise our suspicion more than others, and that's what this chart and what we're going to talk about today. If you're wondering, or you're thinking, I don't know, that's when you want to phone a friend. Get a second set of eyes on this. Hey, would you mind taking a look at this patient before they go? See what you think. And don't do that on your own. It's great to have collective and other trusted friends, colleagues in the clinic. Take a look at this patient. Some kids are ornery and try to get innocent parents or caretakers in trouble. You may think of scenarios where you might have felt like doing this in the past, or your kids felt like doing this, right? You think of a teenager who may be cared for by his grandparents or her grandparents, and they have a very different idea of what child raising and rearing should be, in those skips the generation gap there. So, let's say a warranted taking away of someone's cell phone, a teenager's cell phone. You think they would love that? And they say, thank you, Grandma, for taking away my cell phone. No, probably not. So they're going to say, maybe at this appointment, hey, my grandma's beating me. So they can get their cell phone back and have control in that relationship and do what they want. So be careful of that as well. We'll talk about protecting the caregiver as well. Not allowed to go out with a boyfriend for a time, limited from something, extra required of them, chores, homework, accountability. That's reasonable. If they don't think so in the moment, maybe that's a point of contention in that relationship, so just be aware of that too. We want to make sure we see both sides of the story. And you've heard it said there are three sides of the story: yours, mine, and the truth. And so you want to make sure that you get all the data and make an informed decision. When in doubt, get some help. Here's some things or marks that you see on somebody, a kid that you want to ask more about. You can think about seeing that on a kid. You definitely want to. And what might have caused those things. Sometimes the explanation makes sense, right? If you get hit by a baseball and you got baseball stitches on your arm, leg, maybe even face, and they play baseball, it kind of makes sense, right? But always ask yourself, is there a risk for abuse? Burn marks. Also, sometimes burns are accidental, but if you see these kind of burn marks on a kid, you definitely want to ask. This should raise your suspicion about child abuse. It definitely goes on your differential. I grew up in an old house, and we had a wood stove in the basement. And so as part of our chore, cutting wood, sliding it down to the basement, stacking it, putting it in the stove to keep the house warm in the winter. And so that heat would come from that wood stove up through the duct system and then out through grated, and in some places in the floor where there was metal grates, and that heat would come up through. Well, up on the top floor, that grate would get pretty hot. And one time, I stepped on that and had a burn print in the grid pattern, which is on this chart, on the bottom of my, not my foot, but my house shoe, I guess you could say. And my mom felt so bad. And she, remember Muhammad Ali, my mom, Trivial Pursuit. She felt so bad because the potential for me to burn my foot and have that on it. We put up a barrier there. So part of that is educating your parents to say, is there anything in your house that you can step on? And as they grow and get older, and you don't know if it's your first kid, then the kid doesn't know, and they're going to step on it. So it still makes my mom tear up whenever she thinks of that story. What do you think happened to this kid? To make you nervous, your eyebrows go up, kind of feel uncomfortable, having a conversation with a parent. When you see this picture, poison ivy. All right, we're in psych class. We just talked about child abuse, power of suggestion. So put it on your differential, but not every time, right? We need to say, hey, what happened? Yeah, they got into stuff we didn't know was in the backyard. They got it. We cut it down, burn, whatever. Okay, great. Don't burn poison ivy, please. So part of that is educate the patient too. There's a fine line too, depending on the culture and where you are. Where I grew up in East Tennessee, Appalachia, and I think I talked about this earlier, it's very easy to offend somebody from a different culture and ethnicity or socioeconomic status. So if you go in talking about here's what you do, and it's very objective and matter of fact, sometimes I can come across as, what do you think, I'm stupid? That's how it sounds like you're talking to me. So be aware how this comes across. And so that's when you're practicing with your classmates. Don't just yuck it up and say, yeah, I get what you're saying, and joke all the way through the times that you role play as a patient. Say, as a female, say, no, I get it, what you're asking me in a real woman exam, that makes sense, but don't say it that way. That's super offensive, and that would be, that lady would never want to see you again. So be honest when you give feedback to each other in those role plays. The same way here, to say, I get what you're saying, that's true, but think of a better way to say that, a softer way, a more indirect way, or more on the same team kind of way to talk to a parent about how to parent their kid. Because most of the time, parents, the thing that matters most to that parent is being a good parent. And if you threaten or say they're not doing a good job, that's when the hackles come up, right? That's when Mama Bear comes out. And so you don't want to mess with Mama Bear. You want to help Mama Bear. All right, when taking a history, sometimes silence is a great truth serum. When you ask that question, wait for that response. Remember 36 seconds before they're going to be heard? There's other purposes for that silence, to be able to get that truth home. Truth doesn't need to be rehearsed. Any JAG, cops, OSI in here? Previous job? Lifetimes? Maybe not? Yep. If you've ever been interrogated, raise your hand. That you could say, they've asked me the same question a lot of times. Or you watch a detective movie or a cop movie, they ask the same question a lot of times. Because the truth doesn't need to be rehearsed. You don't have to remember the lie you told to somebody and tell the same lie to somebody else. You just tell the truth. And so the more that same story comes out, the more believable it is to somebody that's interrogated. Don't interrogate patients, but ask them the question. And maybe say, I don't understand. Can you tell me how that happened? Can you tell me more about that? So having it over. How did this happen? I'm sorry, I'm not sure I understand. Has this ever happened before? Having those kind of questions of fact-finding, objective, hey, I want to take care of your kid in a way, instead of walking in going, I know you're beating your kid, and I'm going to get a confession out of you today. And we're not leaving here until we get it. You don't want to come across that way. All right, here's the chart. You got to know this chart. And you're thinking, oh gosh, memorizing the chart. A lot of these are repeated. You can see the burns, the amount of any soft tissue injury is the same across all the edges there on the top. But look for the differences there. It's important to know this as a PCM. Sometimes injuries make sense. You think about a collarbone fracture in a 14 to 28-ish year-old patient, you'd say, man, this baby's made out of cartilage and they got a broken collarbone. How did that happen? Abuse? You think abuse? What would you think was more likely, more probable? Drop? Could be. Probably not going to break their collarbone with a drop. Well, how's a 14-day-old baby most likely did they get that broken collarbone? Traumatic delivery, exactly right. So you ask the mom, how was your delivery? Oh, we had a tough time. His collarbone broke while we were delivering. And you can check the record and say, yep, there it is in there. The OB who delivered it wrote that in there. And you say, okay, makes sense. And they tell you how to take care of it. Yep, we're doing good. Okay, great. Most of the time you don't need to do anything. You'll feel a little knot on there for a while. But check those medical records for correct. Trust but verify in that case. Cruising child, 6 months to 1 year old. You're walking 1, talking 2. Ever heard that? Peds is senior semester, unless you got kids. So 6 months to a year, they start cruising. You know what that means? Start pulling up on things, and as long as they're holding on to something, they can stand up. So they'll start moving down and cruising. And so when their legs get too weak and they buckle, and the edge of that coffee table is right here, and they get that obligatory scar on their chin that most of us have, right? Somewhere here, or in your eyebrow, or somewhere right here. All of us can think of that. They're trying to hide it from here, combing your hair over to your eyebrow. Think about if it makes sense. Man, this kid's running all around the room. And he's got no apprehension with his mom, and he's always got a Band-Aid on his chin. Trust me there. Burns are the same for all kids. Look at that. It's a big chart, it's the same stuff. Look for the differences there. There's your fractures. Wide rib and long bone fractures in a 1-year-old. What did I just say the kids are made out of? Cartilage, yep. Those plates aren't closed, they're super wide, and so when you drop a kid, they'll bounce. Don't try that. But mostly kids are made out of rubber cartilage, and so that's, if they break a long bone when they're that young, it's a big deal. You want to ask what's going on. Here are some other injuries we want to look for. How about intracranial visceral injuries? So abdominal and in your head. Wow, is that a big deal? What about the location of those intracranial inside your head, brain? What's the brain got to protect it? Everything? Huh? The skull. How about your visceral organs? What's fetal position do? Protects it, right? That's a lot of protection, both anatomical location and a vault around that brain. So if that gets hurt, then you want to ask questions. Something that's highly protected, like extension surfaces, right? You bump up against something, that's okay. That makes a little more sense. But you got visceral injuries, shaken baby, right? It's a sad thing. So that's where these things come out. These are the kind of injuries that can result from that. It's hard, and you can see, if you're a parent, you can see how it's not that far getting to that place where in the middle of the night, you can't reason with a 2-week-old to stop crying in the middle of the night. It's your first kid. You didn't grow up around kids. And you can't sleep, and you got to. You got a test on Monday, right? It's not you. It's not you. So think about it. Be understanding for the parents. Don't allow abuse, but understanding where they're coming from, and don't demonize them. Help them. Help them. I educate them ahead of time in protecting those who can't protect themselves. 2-week-old who can't protect themselves. All right, a lot of questions at this point to say, all right, what do I do as far as labs and medical if I find somebody at this state? I'll put this in here for your reference. I'm not going to test you on this, but this is for you just to answer that curiosity and not to distract you from studying for this test. These are off ramps that you can go into and look at for yourself later on. This is a meth lab. It's kind of a beginner's meth lab. Somebody's home. They live here with kids. Maybe you think, yeah, I grew up in that area. That's kind of what I think. At one time, I don't know if this is true, and I still are, but the cops came to church where we were Wednesday night. They asked, hey, can we come to church and talk to y'all about meth? Because apparently where I grew up is the meth capital of the world. So I got that going for me. And they said, we'd like to talk to you about meth so we can educate on what it looks like, and when you see meth labs, and you can let us know and help us and not just leave it all up to us. So they told us how to make meth. Not the whole way. They kept some of the secret proprietary crucial steps, but they kind of told us the steps and what to look for. And one thing that mystified me was there's a point at which in making meth, you put the ingredients, and usually in a red gas can that you fill up your lawnmower with. You seen those? You close it up and you shake it until it's right. And if you don't shake it enough, there's not enough chemical reaction at that stage for the product to be good. Or if you shake it too much, guess what happens? You end up on the nightly news, and your trailer is a million pieces. It explodes. So that, if I didn't have enough incentive not to do meth at that point, but man, that was it. Shake it till it's right. It didn't tell us how to make meth all of it, just to say that. So police raid on this home, and that's what they got out of. What's the difference between this kid and cops? Cops got hazmats on, and the kid's living in there. Means that's abuse? Yeah. So a kid shows up drunk or inebriated or altered mental status. You want to ask questions, right? It's too young to be having that kind of reaction or medical symptoms. So when you see that, have that radar up, always ask the question, have that on your differential, trust but verify. Find a way to come alongside, not accusatory, but protect those who can't protect themselves. All right, sign for neglect, unsupervised, malnourished, and disregard for needs, like that hazmat suit, letting that kid or having that kid live in that environment. Now, most kids get dirty, so if a kid shows up dirty, I grew up, like I said, in Appalachia. My mom did her best, but we went without shoes most of the time, and I grew up on a farm, so you can imagine what I looked like. You know, that was my sunscreen, was the dirt on me. And we called it grocery store feet. I don't know if you grew up on my side of the tracks, but if you walk around a grocery store with bare feet and then you get out and look at the bottom, it is super dark, super dirty. So my mom did her best. There's a chance, this is a chance to ask questions. So maybe this is our first kid, they don't, and again, that maybe not around kids, don't know how and what's proper or appropriate, how they'll survive. They're tough. Yes, probably, but, and say, how often does little Johnny get a bath or shower? Share the benefits of cleanliness, right? Back in the Middle Ages, we found out washing your hands takes the germs away and decreases the chance of infection a lot. So share that with them. Can be difficult to educate, again, without offending or biting or eroding that trust that you've built up. But make sure, and the intent is not to call them dumb or look down on your patients when you're talking to them. Intervene, educate, protect. There's another PDF, I think, in there that y'all have that's abuse that you're welcome to look at. I don't know if you see that. Was that uploaded in your slides or in the page? See some blanks there. No need to fret, or if you don't have it, anything from that, I'll bring into the slides that we're responsible for. But that's in there. I'll double check that it's on there. That's more for your FYI. Do a good exam. Whenever we see on exam, like we said, altered mental status in the kid, means you want to check that out. If parent is hesitant to say, hey, whoa, time out. I don't want you doing that to my kid. Don't take that as immediately as parents abusing the kid don't want me to find out. That may be a good parent, right? To say, whoa, I don't think this is appropriate just yet. I've done that with providers, with my daughter, saying, she doesn't need a passive register. That's our decision, right? She's a minor. Now I'm in charge of her, responsible for her. So have that conversation, and any kind of advice we get, anything we do medically is advice. Right? Besides holding on to somebody for 72 hours to make sure they're not dangerous to themselves or other people, or if they're unconscious, can't make a decision or consent, emergency is they've consented to that, so they can't. And anything else is medical advice. If you tell somebody, hey, you need heart surgery right now, or you're not going to live to see tomorrow, they can say no thanks. And you respect that. You try to convince them, but it's their decision. So don't force medical decision on somebody. You want to be your best salesman. There's a piece of what we do is saying, this is important. I care for you. I want this back. I want you to be better. That's why I'm telling you, that's why I'm giving this to you. That's why I'm prescribing. That's why I'm referring you to people. And not just, I don't care. Whatever. At the same time, don't carry that guilt if they don't choose. So do your best, and it's their decision. So a parent that's protective of their kid having a physical exam to another level or depth or invasiveness, applaud that and say, I appreciate you protecting your kid. This is why I'm thinking this is appropriate in this, and then have that conversation. And it could be to a point where you say, I would offer this if mom or dad, if you would step out into the hallway and leave me alone with this kid for a few minutes and ask them questions about that. Now you don't have to. This is up to you. But this is another step in them learning to own their medical well-being. And I'm going to ask them some personal questions. Y'all welcome to have a conversation about it. Or if you say no, then you can stay in here and I'll ask the questions with you. But that's just an opportunity. There's a fine line there. You want to protect yourself, And if mom and dad says, hey, I was out of the room and they said this and they're abusing my kid in the exam room, then read the room and turn on your spidey sense. So chaperone when in doubt, but that's an opportunity you can help that kid own their medical well-being. And don't lie to the kid. Don't tell them the shot's not gonna hurt. That's not good. My daughter, middle daughter, I don't know if you had this debate, if you're a parent, if you're gonna do Santa or not in your house. In our house, we were thinking, all right, do we do Santa or not? And the rub with us was, at some point, and sorry for the spoiler, they're gonna find out that Santa's not real. Sorry, it's ruined your life. But then, are they gonna say, well, you lied to me about Santa, what else did you lie to me about? And then erode that trust we have with our kid. So, we decided to say, yes, Santa's a real person. St. Nicholas lived a long time ago. He died, and now we celebrate Christmas in that fashion to celebrate what he did and how he celebrated Christ and pointed back to. So that's how we say Santa. Santa's great. Santa's great. So we tell our kids this, and that's how we do it. Well, at church we dropped her off, Sunday school, we came back, and the Sunday school teacher comes to me just laughing and saying, oh man, you wouldn't believe it. And I said, what happened? And he said, I asked the kids, I don't know why he did, raise your hand if you believe in Santa. Well, of course, my daughter raised her hand. And then she said, yeah, he's dead. And the rest of the day, what? But he was damage control the rest of the time with these 3, 4, 5-year-old kids saying, Santa's dead? So we had a parenting going, oh, we should coach our kids up about, all right, we don't want to spoil it for them. So if you ever meet my middle daughter, Michael, ask her, so you said Santa's dead, huh? She's great. She's 21 now. She's okay. Thank you. Yeah, don't tell them it won't hurt. The shot won't hurt. Tell them this will hurt, but just for a little bit. Can you be brave? And now you set them up to do something. And when they have that shot and they survive it, you just puff their chest out a little bit and say, I'm a little tougher now. You didn't lie to me, right? Come alongside. My wife tells a story about our son, Drew. He's 22 now, and I think he's okay. But he was getting his immunization shots, and there was a point when everybody was holding him down, and he was looking at my wife saying, all right, I got a friend here, and bam, hit him in the thigh, and he looked at her like, what? You crazy. But she still, she hated it look that he gave her. He's over 2/3 of the way through the Appalachian Trail in Massachusetts right now, starting in Georgia, so cheer him on. If you follow him on Instagram. All right. What's CW mean? Oh, I heard it. Say it loud. Consistent with. There you go. I'll throw in some of these helps whenever you start documenting. They'll be helpful for you. I'm not going to test you on what CW means, but they'll help you when you're documenting to save you time. There you go. A bonus. All right. So this is potential red flags with respect to the abusive parent, the one who is doing the abusing. This might be what you pick up on and red flags that you want to ask more questions about. Denial, don't know how it happened. Vague explanations, so don't go into detail. Some of that can be from embarrassment, or I did all I could, but still they snuck through the gate, and got into the place and ate the dog food. Conflicting explanations. When you ask that, I'm sure I still don't understand. Can you tell me more about that? And it's conflicting. Then you say, whoa, that's different than what I heard before. Now sometimes that's memory. Memory is a weird thing, and your tech will get mad at the patient because they'll ask them all the questions, and they'll give you the chief complaint and a lot of the back history that they get to, so they'll do some of the note for you. But you get in there, and the patient will say, oh, you know what, now that I think about it, I did have my left arm removed in surgery. And they told the tech they didn't have surgery. And they said, they lied to me. No, they didn't lie to you. They just had time to think about it, and now it's came up. Or, they said they were here for a headache, and then they told me that it hurts when you pee. Well, they didn't want to say that to a 20-year-old female because they're a 24-year-old male. And now it's safer with me. So understand that. Coach your techs up to say, no, they don't hate you. They're not, it's not you personally. It's memory, it's comfort level as a team. Sometimes they're more comfortable with tech than they are weak. So learn that. Partial admission, I did drop them, but by accident, so ask more questions, have it on your differential, have somebody else say, hey, would you take a look at this? Ask them some questions so that you aren't making that decision by yourself. Yeah, and maybe they admit something and not know what they're admitting to and what the ramifications are from that, or they think their relationship with you is good enough that you're going to overlook that, and so don't get lulled into allowing abuse to happen because you know and like this person and you have a prior relationship with them. That's one of the big hurdles if you go back and work in the unit where you grew up or you were enlisted or you have been before, is people know you and they'll say, come on, Sue, just refill my hand again. It's not kosher, it's not good. So having the fortitude to say, I want to do the right thing by you, and I know that's going to not be popular with you, but I want to do the right thing. And maybe one day you'll appreciate that. So there'll be uncomfortable spots and positions like that in your career, but you'll sleep better at night when you do the right thing. This is a pink box, factitious disorder, which we'll talk about in lecture 5 of this block, but it comes up here a lot about child abuse and parental abuse. Somatic disorder that can bleed over into a form of child abuse, factitious disorder imposed on another, and it turns into child abuse. So previously known as factitious disorder by proxy, or most famously Munchausen's by proxy, which is an antiquated term for factitious disorder imposed on another. So we'll talk about it more, but a lot of questions come up right here. What if somebody else is doing this and they're not talking to you? Anybody recognize this picture and who's in that picture? She's a little older now. She's got her own reality TV show. She's got out of the clique. Gypsy Blanchard is the patient, is the girl, and Dee Dee, her mom, deceased because Gypsy Blanchard convinced her boyfriend to kill her mom. Her mom was factitious disorder imposed on another. Munchausen's by proxy was making up or imposing disorders and diseases and maladies on her daughter that weren't there. And so you can see in the picture she's in a wheelchair. She doesn't need to be in a wheelchair. But there are a lot of sad stories. 95% of the cases are moms with kids. Moms imposing this on their kids. So this is another form of child abuse that we need to have our eyes open for. And they'll come in, and there are some other examples. Is this in your slides? You can see that. Sad stories, but think about 323 unneeded doctor visits and 13 major surgeries on a kid that didn't need any of that. Oof. At what point, where were you in that 323, right? We want to be on the front end. We want to say, wait a second, hold on. I know you may think there's something wrong. I don't see anything. I'm not going to refer you to surgery because of this reason. And I think you'll benefit from this. So give them a plan, give them an alternate plan, just don't say no and walk out. But sometimes that can become contentious, right? And mom threaten you. Do the right thing. Live above reproach in the practice as well. And protect those who can't protect themselves. Here's some potential red flags from the parent or caretaker who's not the abuser, but they may be protecting the abuser because of these reasons, right? They might have different motives for lying. They may deny what's going on. They may defend the abuser. He wouldn't, that's not, or she wouldn't, or evasive, not answer the question. They may do it to avoid punishment. Right. They may love that person legitimately, the abuser, and they don't want that abuser to suffer consequences so they know what's going on. They may be protecting that abusive parent. or they don't want to make things worse. If they tell you, and then the light gets shined on this, and we talked about this a little bit before, when they go home, you're not there. So it's just them and the abuser. The abuser says, I told you not to tell them. And then what do you think happens? Probably nothing good. So that may be another reason that they are protecting that person. We don't have to discern people's motives, but we only need to detect when more questions need to be asked, right? Intervention is needed. Hey, we need to look a little more. We need to ask more questions. We need to run some tests. And then more needs to be done. Educate, provide resources. There are a lot of things. If it's underprivileged area, and you don't have enough money for food, and so the kid's not eating, and they're not growing in the growth curve. They're starting to slip out of that normal growth curve. Then say, hey, how's this diet looking? And then you ask those questions and try to be on that same level. Another reason that you sit down when you come into a room is to be on the same level as the patient, and not, all right, mom, hurry and tell me. I'm gonna wait for you to stop talking, stop moving your lips, and I'm gonna tell you you're a bad parent and how to fix that, and then I'm out of here. Don't give that impression. Sit down, be the same level, offer assistance and help, and man, there's a lot of things that will help you. Here's a lot. Which one do you want to choose? Which ones do you want to try first? Come alongside. Women, infants, and children. I've heard of that program, right? Qualify for that. It's your income level, and you'll get free food, basically. That's one. There's many of them. A lot of them. Ask around, be knowledgeable about those programs in your area, and have that at your fingertips to say, man, we can help you. Ma'am, we can help you. And then they'll see you as an ally. And that's more come alongside. It's good stuff. Continue to train your emotional intelligence, your sniff test, not just for bacterial vaginosis, but to say, hey, this is some fish is going, something in right here with this. There may be abuse on the table here. Trust that spidey sense when you're going to ask for anything. All right, legal. Healthcare providers are mandatory reporters in most places, so we're going to say that ubiquitously, that healthcare providers are mandatory reporters until you explicitly are told that you're not. And we are. We're not law enforcement. We're not going to tackle people, cuff them and stuff them, right? But we're going to be part of that, starting that process of asking more questions and bringing in teams to help us understand it. CPS, law enforcement, etc. And ask the people where you work to say, hey, what if this happens? What do we do here? What do we do in this clinic? What do we do in this county, in this state? What are the options? What are our resources? What is WIC? Who's the contact person here that we talk to? Have those things maybe on a sheet in the room, and so you're ready for that. Protecting those who can't protect them. There's some laws. I'm not going to ask you those numbers and laws and when it was or anything, but just know we got to report it. It's a little different in each state, so know what the law is where you are, where you're practicing. But if you don't report it, and there is there, and it's obvious in the note that you documented this for like the things on the chart, burns, fractures, injuries, and you documented that, but you didn't suspect abuse or document your further investigation in that to whatever degree, then it could come back and hurt you in your license if you don't follow through with what you're supposed to do. So this is an obligation for us. Part of you being a healthcare provider, and part of us taking that oath to do no harm, primum non tocere, is to be a mandatory reporter for abuse. There's more on that. HIPAA, and you're saying, I don't want to violate HIPAA. You know, a lot of times if you say somebody went to the ER, that's different than someone was diagnosed with schizophrenia. That's very different. And so you can say things that won't violate HIPAA if you're concerned about that at any point in this process. That can say, hey, I'm suspicious about something. Will you please look more into this? And any legal questions, write those down on the later, and you'll have a legal brief in the senior, and you can be compiling those legal questions for them when they get to you. And right now it's Carlos. He does a good job. All right, elder abuse. Another vulnerable population, demographic needs our help. Now, I'm not going to hold you to the number greater than 500,000. There's a question mark there because there's a question mark about how many are not reported. Well, it's likely way bigger than that number. It's sad. Too much. Elderly have an increasingly diminished ability and frustrating to both themselves and their caregivers to not be able to do what they used to be able to do. So there's that added dimension of kids never were able to do something. They're learning how to do it. Adults, elderly, used to be able to do this. And the famous example is driving. There comes a point in most people when they're unsafe to be a driver. But rarely does somebody say, I see that in myself and here are my car keys. It's a, nope, I'm good, I can drive still, because there's that freedom that they're giving up, that autonomy, and that you may be the one to step in and say, and this is a third vendor in a month, and it's not looking good. And you talk to the family members and those who have custody or power of attorney with that person and have that conversation. So ask your preceptors, how does that go? What do we do with this question?
Just on the statistics here, are there any statistics that talk about care facility elderly abuse versus at home? How much do we see in actual care facilities?
Yeah, probably, and probably a lot because of, and I'm not going to give you a number because I don't know number one, but yes, talking about that to say, the people caring for an elderly person in a care facility are not related to them. And so emotionally, they're not invested. And that's just a job to them, to some people. And they don't love them in the same way a family member does. And so that's some advice that you can give to family members if they have a loved one in a care facility to say, visit them often, and do it unpredictably. So visit them on a Tuesday morning, and on a Thursday night, and a Sunday midday, all the time. And so in kind of an accountability move to say, they don't know when I'm coming, and I'm the one that pays the bills and can blow the whistle, so they got to take care of my loved one to be ready for me anytime. So that's some advice you can give to counter that, not to assume that every care facility does that and abuses somebody, but you're right, it happens a lot. Can happen more than it should, for sure. The short answer is I don't know. So probably not going to have that stat on the test right now. But yes, we definitely need to look at it and be aware of that for sure. So whenever you're talking to your patient and they're forgetting words or not being able to do things, you think about chronic pain, that's something that could be frustrating to the patient, and then they're with a caregiver, whether it be a loved one, maybe an elderly spouse as well, or they're living with a family member, or that caretaker at the facility. That's the only people they have contact with, and the frustration gets vented to that person. And so that could come across as, man, this is a ornery cuss. And yeah, they deserve it. We don't want to let that happen, right? On the other hand, you want to take care of the caregiver as well. Because you think about an elderly couple and a male, maybe he's demented or angry because of things he can't do, and lost a leg with diabetes, and now he's got to ask his wife to help him more things, and that's frustrating him. And the wife is maybe a couple of years older and she's not in good health. It'd be easy to hurt her, maybe even unintentionally. So watch out for it. That's part of your spidey sense and sniff test is, how's the caregiver doing when I'm seeing the patient? How's that dynamic? When's the last time you slept? A good night's sleep, man. Asking things like that. We'll talk about two main types of abuse, physical and emotional. There's a lot of different subcategories to these types of abuse. Or physical, emotional are the big categories we'll talk about. There's verbal, nonverbal. You can probably imagine different types of this. Physical abuse, looking for things, look at this next slide, signs and indication of those. Bruises, somebody's holding, grabbing them, right? And that could be somebody that's on aspirin and easy bruiser. And they got to move them in the bed a lot, and they can't move themselves, and they may be heavy. And so you gotta grip them pretty tight to move that. There's a plausible explanation, but you wanna ask that question and maybe say to the caretaker, hey, I'm noticing a lot of bruising here. All right, how are you doing that? How are you moving this patient? You know, or use the bed sheet method and maybe play dumb, you know, a little bit. Or just asking questions to say, what are your options for this not to happen? Because we want this not to happen in some way. And then you can, you can add even a tactic or an approach to say, hey, some people might see this as abuse, and so I don't want you to get in trouble. And if it just could be a technique on how to turn somebody in bed, so you can come at it that way, the same team, if you think it's an innocent something. But again, phone a friend, get somebody else's eyes on that. That's good. Other places, other things, emotional abuse, unexplained withdrawal from normal activity. Sometimes it goes silent. If you're in a place like a care facility and they don't have control over their schedule or diet or a lot of things in their life, then if they say something, then they may get more privileges taken away from them, or it'll be worse because, well, I know you visited me on Tuesday morning and Sunday afternoon, but when you're not here the rest of the days, you know, they don't like that. So I hear that and I feel that. So you don't want to feed that. You want to be asked questions and maybe just them changing their mood. Maybe sometimes there's what's the first rule of psych? Exactly. Somebody gets a little ornery or altered mental status in an elderly female. I don't know if y'all know this yet, but what's something you might look for? UTI. Exactly. UTI in elderly can cause altered mental status. And we won't have that on exam, but to say there's another reason, so have your differential broad and wide, and don't get myopic. Put it on the list and start rolling them out. Good. Read the room. Trust your gut. Legal, again, we're mandatory reporters for all abuse, and that's what we're going to say. We're mandatory reporters for all those. Protect those who can't protect themselves. We're not law enforcement, right? Again, we're not tackling them. We're starting that conversation, making sure it doesn't propagate or happen more. All right, domestic violence and abuse. You're saying, wait, haven't we been talking about that already? Remember on the bottom of pink box, I get it, we don't have pink box here, but it's true with anything where you diagnose it is not better explained by another diagnosis. So do you think child abuse and elder abuse would fit under the umbrella of domestic violence and abuse? Could. So there's a category of people who are not children, and not elderly, who also experience abuse and violence, and that would be under this umbrella. But if they're a child under this, then maybe a better explained by child abuse. If they're an elder in this category, it might be better explained as elder abuse. Does that make sense? Yeah. Violence is referring to physical. Abuse could be physical or emotional. Bullies, a lot of times come up in conversations about this. We'll talk more about bullies and personality disorders, conduct disorder later on. Victims, 90% of the victims are female, which means not all the victims are female, right? So you read the room, have that on your differential. Don't think less, or don't call somebody while you're less of a man or less of a woman because you're being abused. That's some of the lies that they're believing probably already. Come alongside them, but be wary of that. Spend a little more time checking on your pregnant patients. Why is that? Why spend more time checking on pregnant patients? Why do we talk about children and elderly? What was common in their situations? More vulnerable. We think about pregnant lady. More vulnerable. Do you think the ability for her to do things has diminished during this time? Do you think the burden that she might be or might feel like she is on other people increased? You think about somebody who hasn't slept or has morning sickness. Yeah, that could be annoying to some other people who may share a space with them. So spend more time, or that pregnancy might not be wanted by the other person. So spend more time checking on your pregnant people. health risks this could come with, is what might be spin off of. So if you see these things, have it on your radar, have abuse on your radar. When in families, if children witness violence, a lot of times they are more prone to replicate that or revert to, that's what I know, so that's what I do. Same with marriage. That's what you grew up in a home and saw all around you. And then teens. The quicker we can catch this, the better. Because when teens, they got more resources, more freedom, more means, more physically developed, stronger. So more money, more problems, right? And there's greater ramifications to their decisions. So the sooner we catch that, the better. So a 2-year-old throwing a temper tantrum in the middle of the grocery store, it might be cute. A 12-year-old doing the same thing, probably not the best thing, and you worry about it. So you want to help parents in a trajectory to say, I know that may seem cute now, this might be what that develops into. Here's some suggestions, parenting, that you might consider in that way. All right, let's take 10 minutes, we'll finish this up, get on 10 minutes. We saw in child dental abuse, but there are some things that we say, rule out other organic etiology. Injuries in different stages of healing, meaning there are multiple injuries, some are fresher than others, and so it's happening multiple times, and the old one is healed almost all the way up, the middle one is not, and then the new one's fresh. If you see that, that could be a problem. Hidden clothing, maybe wearing a big jacket in the summer, long sleeves, they don't want to pull up or take off their shirt, and then you think about what's an organic etiology that causes it. We haven't talked about psychotic episodes, but somebody with schizophrenia, they think that's what they're supposed to do, or voices telling them to do that. That's a different story. That's another diagnosis. But somebody who's got marks on their arms and they don't want you to see that, then you want to say, ooh, I got to think about abuse. Make sure we're not missing that. Delay in seeking care. So somebody who's got a partially or maybe a malformed union of a broken bone, it's pretty obvious. And you say, why didn't you get care for this? Well, I didn't think it was that bad. All right, whoa, we got to have a conversation about that. Or somebody who speaks for the patient, partner persists or interrupts them, or the partner would look to, the patient would look to the partner for the response when you ask the patient a question. Sometimes that's a kid who's young and doesn't know how to have a conversation with an adult, and their safe place is their parent, and so they're asking them to, how do I answer this, and tell them what they're asking. But also that could be, I'm scared to say the truth, and so I'm looking to my abuser who's going to clean it up and give them what would make it not worse when we go home. So read the room, same objective sequence could have a very different feel whenever you're in that room. The victim might blame themselves. That's a lot, like we said, a lot of the lie that is believed could be that they're propaganda, that the abuser is feeding them, you deserve this because of your behavior, and so you get punished because of it, and that's a sad thing. There might be creative ways to separate the victim from the abuser, to ask them questions directly about this. Hey, the tech, I'm going to come down the hall with me, check your vision. Abuser, don't call him abuser, but you're going to stay here and tech so-and-so is going to get some more information from you. We'll be back in a jiffy. We're just going to go check your vision. So you separate them and you watch about how that happens and what goes on there. If it's especially if it's an adult, and they're legally allowed to be on their own, and that abuser say, nope, I'm coming with you. Okay, I get it. Maybe you love them, and you want they're just off their honeymoon, and they want to be together, and they can't be inseparable. That's a different story. But if this is abuser vibe, and there's some abuse there, and you say, ooh, they don't want to separate because they might not clean up the story enough, and that might implicate maybe in this abuse that is going on. So you want to be aware of that too. And you also might get frustrated with this patient come to see you. The abused patient comes to see you often. We talked about that a second ago, but different scenarios about somebody comes to see you every week, and you're thinking, no, there's nothing wrong with you. Why do you keep coming to see me? And that maybe their only chance to get out from under that abuser by themselves is to come to the doctor. And so ask the question. Say, do you feel safe at home? How's it going? What's your life look like? What's your home life? So who lives with you? What goes on? So ask those questions. If you're looking at factitious disorder or somatic disorders or saying, you're telling me there's something wrong, I don't see anything wrong, before you just slap somatic disorder on it, body dysmorphic disorder, you say, how's it going at home? Who's living with you? So ask those questions. Risk factors common in victims. So prior history of, IPV is another abbreviation that's on things. Intimate partner mouth. So usually female, like you said, 90% female, but that means 10% are not female. Younger age, and then using substances or risky behavior, and yet you kind of ask, is it a chicken or the egg, cart or the horse, which comes first, abuse or risky behavior, risky behavior or abuse. But create a mental picture of this patient and say, I want to recognize this patient when they walk into my exam room. And that's what you want to do when you read these things that could be going on in victims. Is that what you want that to trip a flag? You want that to set off bells and whistles in your mind. When that patient walks in with some of these or even one of these things, you want to say, there's potential for abuse here. I need to have it on my radar and put that on my DDX list on the upper right-hand side of my SF 600. Right, so have it on your radar. Have it on your differential. Sadly, before too long, you'll have real faces associated with these diagnoses. Relationship factors, so if you see a couple comes in, this could be, and a lot of times is a source of contention that might lead to abuse. Don't assume that it will, but if there's disparities between income, they grew up on the opposite side of the tracks. You know, sex and money are big reasons for people to get divorced, and contention in marriage, and so different views on what money is and how to spend it. And you can see that even in generational gaps, people who were raised by people who went through the Great Depression. You know, they're much more of a hoarder for a reason that they think we're not going to get to see it. Instead of, now it's tiny houses and minimalist, you know, get rid of stuff, get rid of stuff. That's a very different approach to things, money, etc. Educational, you can see how that may be coming into play and looked at like an idiot, kind of feel that way. You always talk down to me because I do things wrong. And you think you are smarter and got a better way to do things. Well, maybe that's true. Just because of an education you have in a certain area, or that patient does, or that patient's caregiver or spouse. So be wary if there are disparities in this. Community societal factors. There's a lot of different cultural expressions too of this, cultural pressures as well. There are some shame, honor, family culture where it would be taboo to speak up for yourself. And so you go down with ship. One time, shame, honor culture famously is East Asia, and the family name is more important than the individual. And the highest incidence of suicide per capita at one point was in Japan. And the common story is they get up, dress, and go to work. And many weeks before they were fired, but they didn't tell anybody because that would be shame and disrespecting the name, but they still get up, get dressed, go to work, look for work, and they don't find it, and one day they just don't come home because they stepped in from the train at the metro station. So that's a very different approach than somebody in an individualistic society, more Western culture, that might be more prone to throw others under the bus, parents included, to say, I'm my own person, and you can't keep me down. It's not my fault. I'm going to change my name. Right? Something of that nature. You can see how the cultural differences, depending on where you grew up, how you grew up, Appalachian, different side of the track, etc., could be factors. So seek to understand where they're coming from. Seek to understand the struggles and the propensity from where that patient's coming from, and ask the question to know how to help them. So risk factors that would might lead someone to be an abuser would be this. They saw it as a child. They have some trauma that's unresolved. They have some instability where their world got rocked. So they're taking it out on somebody else. Right? Go home and kick the dog. But this time it's a person. It's not good. Substance use. We talked about the risks about using, right? Just mainlining cocaine in the rearview mirror and your eyeball explodes. You probably wouldn't have a problem. That type of person, I'm not saying about my friend Crusher's employee, that might be something where it wouldn't be a far of a reach. You could see that the abuse that goes around them because they don't have, or they have something that's going on. Be a proponent for counseling and be a model of that. Do that yourself. I think I told you, we told one of our kids, hey, I think based on what's going on, you benefit from some counseling. And their response to us was, in essence, no, y'all don't do it, so why do you do it? That's crazy. That means I'm crazy. And we said, oh, we probably don't model that very well. So we went to marriage counseling somewhere, saw some things, worked on some stuff, and got tune up. You might call it that way. And that's how you can maybe sell it or give it to your patients to say, have a tune up. You tune up your car so it runs better. How about your marriage? How about yourself? How about how you see the world? Tools that you can use to cope, live in, function in the world. Why not do that? I'm not calling you crazy. I'm saying, why not do life better? And I got some friends that can help you do that. So be a proponent for that. Physical effects of something that could be going on, that's a pretty broad list right there. So somebody who has that stuff, have abuse on your radar to say, not just those things, but anyone. Have your emotional intelligence, your sniff test, your radar up to say, I know you came in for a headache, but I want to ask and do my due diligence, OPQRST, sample, ask those questions, so I may pick up on something that would cause me to ask some more questions and get to that abuse that's buried under there. You want to tell me, but you don't want to tell me. I want to help you. So build that trust. Moral of the story, looking at this list, no one's immune to domestic violence. Ask the question and keep training your emotional IQ. Some health effects, what could happen for those who are abused? A lot. Badness. We don't want it to happen. We don't want it to let it happen. Checks. We talked about this a little bit. Be direct and diligent, but careful. You don't want to make it worse or drive it deeper, right? Maybe you have to check the vision down the hall. We'll be back in a jiffy. Then you can ask those direct questions, not in front of the perpetrator. And those are some example questions that you can ask in direct inquiries when you're talking to the patient. And then what do you do for them? You want to have a plan with them. You don't want to just give the impression or even overtly say, well, it sucks for you. See it. I gotta go see another patient. You don't want to come across that way. I know that's part of what you're thinking is, man, this is taking up a lot of time. I got 20 minutes to see, and now I got to see another patient. I got 18 more patients to see. That's on your mind, back your mind. But this may be one when it blows up your schedule today. It's worth it, right? And you get into that next patient, and you're 20, 40 minutes late too, and you sit down in their room and say, the patient prior to you needed extra attention, and I want to give the same amount of attention to you. And a lot of times I would go there, where were you? I'm here too. But if you try to rush through that next one, yeah, refills, okay, see ya. And that patient's gonna go, what? I've been waiting 3 months for this appointment. And now you just pencil with it, and you didn't even listen to me. So, be a good provider. And you'll learn how to be pointed. You know, when you come into a room and sit down, you don't just say, how's it going? What are you going to say? What brings you here today? You look at your chief complaint and you say, my tech tells me you turned your ankle playing soccer yesterday and now you're having trouble doing stuff. Tell me more about that. And then you be quiet. Now you're talking about the ankle. So there's tips and tricks, and that's your clinical work next semester. Ask those questions. Hey, how can I get better? How can I How can I trim this time to be better, more efficient? And then sometimes, for the treatment, when you know something's going on, you smell it, it's obvious, it's in the room, but it's, nope, nothing's going on, ship shape, all set. Then you can play that, I'm asking for a friend game. If your friend has this problem, and I play this a lot with operators, it's like, I got a friend, and if they had back pain, and they came and saw you, would you deliver them? I say, well, if I'm talking to your friend, and they can do this, this, and this, then no, I wouldn't. Oh, well, that's me. Yeah, I know. Yeah. So we have that conversation. Well, you tell your friend that, yeah, if they can't do this, putting other people's lives in danger, then yeah, I'll probably have to push the pause button for a period of time to get them back up and running. And if they're able to do it right now, and they don't have anything going up, and maybe an operator training, you have that conversation and you work with them. But sometimes you say, nope, you're a danger to yourself and other people, and I'm going to be the bad guy here because I want to protect you from you and other people. I wouldn't put people on the plane that you're flying today. So we got to push the ball. So that's a tough conversation. But many times you don't have to go straight there. But you can play that what if question game with your friend. If your friend were to, this is what I would tell them. So if you talk to your friend, you tell them that. Not doing it alone, having a team, putting another set of eyes. This is who you want on that team. Your command team, family advocacy program, SART, right? Sexual assault, people on your base, post, and then law enforcement, CPS, all those people. You want to ask the questions. What happens if this happens in this clinic, in this county, in this state? What do we do? What do you do? What should I do? And have that question. And you talk to your techs so they know too. So it's in the surprise, and you're learning on the go, on the run, whenever it's needed. You don't want to learn, when it's live. Questions? While I switch. Next, anxiety. A lot of big words. I'm going to test you on spelling and all these. No, I'm not. Look at all those. That's a bunch of anxiety, a bunch of phobias, huh? Look at that last one. Paraskadecatriophobia. Fear of Friday the 13th. If you stare at this slide long enough and look at the background come into focus, you too can have this phobia. Jason Voorhees in the background. Fear of Friday the 13th. All right, anxiety. Some treatment gets a little more nuanced. Pay attention, like we do, like y'all did a great job of. Acute versus chronic, how you treat different ones. That'll come into play in this block as well. So pay attention to what's being asked, the questions being asked. Are you treating them now? Are you treating chronic? What's going on? What are we after here with this patient? Let's practice a little bit. All right, what's the question? Most likely, right? So that may point you into what has the most evidence. We don't have all the criteria. And experiencing. It doesn't ask for a diagnosis, right? What does this question smell? What lecture are we in? What just the question? Abuse. All right, good job. What lecture we just talking about? Yeah. So no pink boxes in that one. We refer to one, we'll talk about later. But no pink boxes in that lecture. So we got to ask it as experiencing, not diagnosed to it. All right, we got adult or child? All right, super adult. 91. That's older. All right, so what category? What part of our memory house are we going to? Memory palace are we going to in that abuse lecture now? Elder abuse. Good job. Where are we? ER, PCM, PCM. Why is he here? Yearly checkup. Not emergent. No reason, right? He's just here. What's his situation? What's his look? You did a good job. Sample. What's your living? What's your occupation? Where you live? So where does he live? Nursing home, care facility. What's the lab work is unremarkable tell you? We ruled out organic etiology, right? Good job. You guys did that. What's PHQ-9 for? Depression, yep. So what did they have to pop positive to get the PHQ-9? PHQ-2, right? One of those two together, and then we need how many more of that PHQ-9? 4, yeah. Depression, good job. For 2 weeks. Maxed out, what does that mean? Brother's feeling down, depressed, and hopeless, and it's not. So what is it? What is observable in here? A new flat affect. New flat affect. What does that say? Wasn't there before, right? It's new. And what does that tip you off to? Elder abuse? Something's going on? What's the reason for this new flat affect? States his family refused to visit him. Family refused to visit him. Would that be a reason to be down depressed? Yeah. Why are they not visiting until he starts giving them money again? Oh. Family drama. Turned into a Lifetime movie, right? And his new girlfriend. 91, got a new girlfriend. I don't know what kind of nursing home it's in. She refused to talk to him until he starts answering me. Well, dancing at 91, good job, buddy. You're doing good. Well, what is that? What are those 2 instances of right there? Abuse, yes, but what are they doing? Manipulating. Yeah, they're trying to get something out of him by not giving it, right? So they're manipulating him. Frying up fish fry. Hey, I want to go frying up fish fry. All right, so let's look at that. That's elder abuse. Okay. Is there any evidence of physical something? Okay. So let's look at our answer choices. Elder neglect, interpersonal violence, physical abuse, emotional abuse, dementia. So we have 2 that require physical something. Which ones are those? Interpersonal violence, physical abuse. All right, so they're off the table. Now we're down to 3. Good job. All right, so elder neglect and emotional abuse and dementia. What's dementia? We don't know, right? We haven't talked about it yet. You'll get to that. That's confusion, repeating stuff, what's going on? That's an elderly lady with UTI with Alzheimer's. It looks like dementia. Well, we don't know. We haven't talked about it. That's off the table. So now we're down to elder neglect and emotional abuse. What is neglect? Not meeting basic needs. Disregard for basic needs. Left unsupervised. Or they appear malnourished or starved. Do we have any of that going on? What's the only one left? Emotional abuse. You get manipulation. You get something would fit into that? Yeah. Sometimes you get to the answer by ruling out the other ones, and the most likely is the one that's left. So that's the case here. Good job. So there it is from our slides. Elder abuse. I'll give you these at the lab so you don't have to run down an extra video and so you can go back there and freeze it. It's good. Next question. All right, what's the question? Most concerning, which means there may be more than one that are concerning. Right? What's the most concerning? For possible child abuse, which means it could be explained by something else. So what's the most concerning thing here? All right, is this an adult or child? Child. A super child. Really young child. And where are we? PCM. Why are they here? Fever. Sick. Yep, fever. Okay? So that's not why they're here. That's not on the radar. They're here for a fever. So you got your IQ up. you're doing the sniff test and saying, what's going on in this room? So mom reports child is not fed well for about 4 days, producing 3 wet droplets a day and not sleeping well. Who's got kids? Mom. Yep. Whenever your kid is not fed well for about 4 days, what does that mean for mama? Is mom sleeping like a baby? That's a terrible expression, right? Sleeping like a baby? No. Mommy's not doing good. Not fed well for 4 days. And so you think about mama, ooh, mama, how you doing? Because she hadn't fed well. And you look at mom, you see those rings in her eyes. She's, what help? I got to do something. That's kind of what you think of when you think of this. Okay? 3 wet droplets a day. Is that a lot? We don't know. That's not good. It's not on the high end. It's not on the high end. So they're getting some food, but not a ton. Not sleeping well. We got that. And on exam, child's febrile. We know that. That's why they came in. Irritable. If that's concerning. No, that kind of comes with the territory, right? Fever, irritable, yeah, they're sick. Screams when the period tries to look in her ears. Is that stranger danger? That's just being sick, right? Yeah, I don't feel good. I want you to touch me. I'll give you a trick on how to look at kids' ears in a second. And signs of tooth eruption. What does that mean? Teething. What else is signs of teething? Drooling, fever. Yep. Not eating well. So it could be teething. Got it. It's gonna pass pretty soon. Good job, mom. Go home. Nope. We'll do. We got some other things we're learning peds. I'm not gonna tell you those right now. But yeah. What else is going on here? Mild bruising on anterior tib fib. What about that? All right, so what comes to mind, or what do you think, oh man, I didn't have time yet to memorize this thing, but he told me I need to know it. To know about injuries, burns, fractures, and other stuff. That chart, right? That chart. And what was the first chart and the age group there? And it said, any injuries under what? 6 months. Any injuries under 6 months. So this is a reason right here. You need to know that. You need to know that chart. Any injuries under 6 months is concerned. What about this? Tib fib. What age would you consider that out? Yeah. That was it. 12 to 16 months. Yep. They're walking. They're cruising. They're moving around. They're exploring with a huge thing on top of their body that gives them off balance of their head. And so they're banging into kicking stuff, and you think, yeah, you got that obligatory chin scar. I got bruises all over the place. 5 months old, what happens when you put a 5-month-old on a blanket and walk away and come back? Where's that 5-month-old? Right where you left them. They might have rolled over. That's it. So bruise and tib fib, that's concerning. How about normal CV pulmonary? What's CV? Cardiovascular pulmonary. Because we listen to heart and lungs every patient. I know your ankle sprain. We listen to heart and lungs. Normal CV pulmonary exam, what does that tell you? What are you concerned with? Fever, kid, CV or pulm disease, right? You want to make sure they don't have sickness. That's saying it's good, because we're rolling out organic etiology. So what do you like here? I kind of pointed you to it. That's the one that's concerning. Tib fib bruising. There you go. Any injury in the 6 months. So practice tip, when you're listening to or looking in kids' ears, save it till the last thing, ears, and then looking at the oral phonics. And tell the mom, all right, mom, you sit in the chair, and you put the kids, sit them on your lap, and put the kid's legs between her legs. So she clamps down there on her kid's tib fib, right? And the kid's maybe facing this way first. And then you got one arm next to mom, and the other arm she's got down this way, so she's got that left arm around the kid's arm, holding close to her. And then the other arm goes around the kid's head, right here. So she holds that, head close to her. That kid's not going anywhere. Unless it's the parent's first kid, and then they'll root for it. If it's a second or more kid, that kid ain't going nowhere. She's got it held up. You look in that ear, good. Flip around, doing the same thing. And by the time you look in that second ear, that kid's screaming, and you turn and look in their mouth because they're, look, their oropharynx looks good. And then that's the last thing you do. There you go, that was free. You tell Major Klein, welcome. So concerns there from our slides. There's the chart. Any injury under 6 months old. Good job. All right, anxiety. We'll go through these a little quick. A lot of it's repetitive, but we'll talk about them as we go. There's where we find it in our reference material on the left. On the right are the things we're going to talk about. Some of the basics of GAD-7 functions a lot like PHQ-9 does with depression. GAD-7 is general anxiety disorder, 7 questions, will function that same way for anxiety. So this is a measuring tool, both initially and follow-up to see how they're doing. And it's questions that they answer, and so you say, oh, your score is getting better now that we've treated you in this way and this way. And so you can track that progress, a subjective thing, and an objective number over and over. Asking them the same questions. Hey, same questionnaire, fill it out, see how you feel today, and then we'll see what our treatment plans do. But don't forget the first rule of psych. Rule out organic ideology. There's an example of GAD-7. Again, at the bottom right, there's the scale. Don't show them that scale. Don't let them game the system, either by overscoring or underscoring it. Just give them the questions and have them circle. We need to talk about definition of terms a little bit. Fear is an emotional response to an immediate threat. So think about responding to an explosion. That's what fear is. Anxiety is more the future threat, or kind of a slow burn about something that might happen in the future. And so it's always an underlying slow burn of that anxiety. So that's a little bit of difference in how we'll treat them in this class, those 2 words. Fear and anxiety. These are definitions you'll need to know. They're pretty self-explanatory, just need to be on this definition slide. Separation anxiety disorder doesn't have to be a kid. It doesn't have an age discrepancy there. But fear of anxiety being removed from something. And if you have something due to another medical condition, what do you have to have in the question? What do you have to know? There's something else. There's another medical condition. Or if it's a substance in a question, you got to have knowledge that there's a substance involved to call it that, right? So those are more so diagnoses of exclusion after you've exhausted the others. All right, first up, specific phobias. Remember systematic desensitization therapy, where we expose them to a little bit and then a little bit more, and see, that wasn't too bad. The OCD person, all right, let's flip the switch only 13 times instead of 14. Did anything bad? Okay, next time we'll try 12. That's what systematic desensitization. This is all gas, no brakes. Hashtag don't do this. Somebody with arachnophobia, and you dump a bag of spiders on them. Don't do that. I would like to see whatever readings they got on whatever she got hooked up to in her chart. That would be something to study. We love her. We want to take care of her, for the record. Don't experiment on patients. Here are the specific basics of, in a name, it's specific. There is something, there is a thing that they're afraid of. Always assess for suicidal and homicidal ideations. This is somebody's specific phobia, especially in the moment that they feel out of control. They do not feel in control of this situation. So anytime you introduce somebody to that, then not wanting to go into that state again is an option in their mind to say, well, I don't want to deal with that anymore. So then you start thinking about suicide, homicide, or the patient does. So always ask. What else could it be? A lot of things. We'll talk about some of those today, but there'll be some nuances to be able to differentiate between. Here are the basics. This is the pink box distilled. This is my interpretation of the pink box. So read the pink box just to make sure we job and you think the same thing. What's fear? How do we say it? Fear? What do we call? What's fear? Yeah, emotional response. Responding to a what? Explosion, something, boom, right now, right in front of us. That's fear. Good. Immediate fear. What's anxiety? More of a slow burn. Afraid about what if something happens in the future. Yep. So something who has that response every time that thing is introduced. Let's say spider. Every time they see or close to a spider, boom, they explode. And then there's always an anxiety. What if I see a spider again? I avoid things. I go around. I don't live in certain parts of the country because of that kind of. I don't want camel spiders in my garage. Right? Anybody see a camel spider up close personally? Those things are huge, aren't they? Yeah, like a spawn of Satan. Incredible. Don't tell me if you have a pet. You named it. Some people have arachnophobia. I'm okay with that, but please don't bring a camel spider to class. Yeah. There's a time component, 6 months. We're going to have over 6 months for this to count. And then clinically significant distress or impairment. So it affects things that's going on. They're seeing you. They're asking you, hey, I got a problem. Help me. That's clinically significant and it's impairments affecting stuff that's going on. Good. You've seen a lot of this. This is a lot of TikTok and YouTube video fuel right here. This is why those things exist. If you tie the rubber snake to somebody's ankle with a fishing wire, and they're afraid of snakes. I mean, that's a good video, right? That person's traumatized for the rest of their life. That gets a lot of likes on it, doesn't it? My wife will laugh for days about stuff like that. It's hilarious. It's a big deal for them to endure, and you're saying, it's just rubber, it's no big deal. Do y'all remember what John Madden's fear was? Flying, yeah. What was the thing that he did? Went to great lengths to not fly. What did he have? What did he ride in?
Bus.
The Madden Cruiser, right? A bus. So this guy was on Monday Night Football for how many years? A lot. And so he went to, you think all the cities where NFL games were, he never flew. He always rode a bus to this because of his fear of flying, specific phobia. And it was impairment. He changed a lot of what he did because of that fear. There's a big box, read it, make sure it makes sense to you. What do we do for it? Say it with me. CBT. There it is. Behavioral therapy. Behavioral therapy, CBT. Address the behavior, making a plan, recognizing the first. Second is systematic desensitization, right? A little bit closer. We're gonna have a picture of that animal across the room just for a couple seconds, and then we're gonna walk out of the room with it and see how that is with you in the room with it. You get a little closer, a little closer. There's a lot of other therapies that are options for that, but those are the first two that we're gonna put on our list. For non-pharm and first line treatment for specific phobia. When we get to meds, if that non-pharm doesn't work, then we get to meds, we use propranolol, which is a what? Beta blocker. Yeah, what's beta blocker do? Upper or downer? Downer, that's pretty good for anxiety, right? Downer, propranolol. So if you have a specific or a predictable phobia, propranolol is great. You take it before you get into that situation, and you know you're gonna have to face that, propranolol is great for that. About an hour, 30 minutes, an hour before that. What's somebody that you might want to think about before you give a propranolol to? What's propranolol do? What's its main use for a beta blocker? Slows the heart rate, which helps with what? Blood pressure. Yep, hypertension. Yep. So if somebody already has borderline low hypertension, but watch them when you give them propranolol. If you drop their pressure, even if they're on the upper end of normal, and you drop them, they can have orthostatic hypotension, fall down with their head. Now you got no problem. So fire beware. But for predictable anxiety, propranolol is great. CB10 meds is better than mono, greater than the sum of its parts. Same thing here. So if you need meds, Don't neglect CBT. It's good. Propranolol can be taken PRN. You don't have to let it build up in your system. Famously for performance, and we'll talk about that in a second. Like right now, social anxiety disorder. Does that mean look familiar or relatable? Some people recharge socially around other people, and some people recharge by themselves. So just that because you recharge by yourself, don't think that you have social anxiety. There's a big box and there's DSM criteria. Not everyone who recharges alone has social anxiety. These are examples of that. And the distinctive feature of this, because you're looking at those things on the left and you say, well, that could be a one thing and a certain thing and a specific thing. I might call that specific phobia, right? But the distinctive factor and a better definition, a better diagnosis, is when you're under the scrutiny of others and you become anxious because of that. That's when it turns into social anxiety. When you're under and exposed to the scrutiny of others, and that's what bothers you, the thing might be a medium for that to happen. You get up in front of people. What's the number one phobia of humans? Glossophobia. You know what that means? Public speaking. Yeah. To do this, to stand up here. Not saying I'm Superman. I'm not great at this. But to say public speaking is number one. So when people get, oh, I gotta go give a speech, or I gotta stand in front of a lot of people, and man, my heart rate goes up and all these things happen, that's a specific thing, but it's the scrutiny of others. Whenever you're under the scrutiny of others, that's when it turns to something. Here's what it has to be. So this is asking for a friend, right? You're going down, recharge by yourself. Exposed to scrutiny by others. Fear of saying that out loud, because other people make fun of you or saying, like, no. And then social situations always provoke this. Not if just one certain person's there, right? Maybe you got a crush on them, or you had a bad experience, but it's not that. It's always the social situations that always provoke this. You avoid them and endure them with anxiety. OOPT, what's that stand for? Out of proportion to, yep, actual threat. So they're way more afraid than they should be. And other time components, same thing, 6 months. There's the mini box. First line is take. Systematic desensitization again. Maybe you tell your speech to your spouse. And then you tell it to 2 people. And you work your way up to it. Good. If we need meds, greater sum of its parts. If we're going to use meds for social anxiety disorder, then we use Muhammad Ali. We use SSRIs, right? If we're going to do long-term management. If we have a predictable anxiety, propranolol is a good one. Gabapentin, I put it on there. It's off-label use, so I'm not going to ask you about it, but you'll see this a lot in clinic. There are some meds, gabapentin, one of them is used for a lot of things off-label. And you'll get there and they say they got social anxiety, so they're using gabapentin. Major Campbell didn't tell me about what he doesn't know what he's talking about. Well, it's off-label, and so you're risking to a certain degree using a medicine off-label. If something wrong goes wrong with it, happens, then you didn't follow the law. So have good reason. Talk to your mental health providers in your area and say, are you comfortable with this happening? And yep, all good, all day. Okay, Dr. So-and-so, or provider so-and-so, collaborate with, advice with, maintain medicine. Spread liability, and if it's the best thing, a lot of times it is, but just be wary when you use the med off-label, that you use it off-label. Now, social anxiety and benzos. Benzos work, very powerful, they work, be careful, because they'll be back. Because they work. Careful. When you have something, and a lot of times a specific phobia, if you schedule somebody for an MRI, and they say, hey, I'm going to need diazepam. Every time I do an MRI, I'm going to need it because I'm claustrophobic. And you look back at the record, And every time they did, yep, they got 2 bouts of pain. One an hour before, another one 30 minutes before, it's still bad. That makes sense. That's very reasonable, and it happens a lot. But just say, careful when you're doing benzones. And you'd much rather give propranolol, predictable PRN anxiety, than a benzone because of the risks involved. Panic disorder. High hopes about the second block. Anybody? High hopes. Okay. Unexpected panic attacks. So there's a difference in attack and a disorder. An attack are physical and cognitive symptoms, and the disorder is worrying about having another one for over a month. How many panic attacks do you have to have panic disorder? 1. It could have been 10 years ago. That's a sad state, right? But you just need to have 1 panic attack to have panic disorder. If you have panic attack, but you're not worried about another one coming, you don't have disorder. When you have worried about another one coming for 2 weeks, you have panic disorder. Not yet. If you have panic attack and you're worried about another one coming for 2 months, you have panic disorder. No. Time component. 1 month of worrying about another. So physical symptoms, it can't just be one thing. Here's what those 4 things need to come from. So I'm not going to ask you to count those things. I'm going to say, what does this look like? What does this smell like? So you need to know what a panic attack looks like. And is this when things get spun up or spun down? Spun up. Yep. Things get excited. Things get faster. What else could cause these things? Say again? Adrenaline. Yeah. Natural or exogenous. What's an exogenous form of adrenaline or stimulator? Ooh, I just said it out loud. Stimulants, right? Drugs, meds, something else could be causing this too. So be conscious, be wary of ruling out organic ideology before we say it's a panic attack. It might just be cocaine they didn't want to tell you about. Could be something on there. Could so become. All right, we'll talk about. We got a little ways to go, so we'll stop there. And next time, I'll see you tomorrow.